All right, welcome to the sharp end of medicine, where every single second counts. Today, we're diving headfirst into the high-stakes, high-pressure world of neurological emergencies. So I want you to picture the scene. The call comes in over the radio. EMS is just 5 minutes out. You hear the story. An otherwise healthy person sitting at their desk 1 minute, and then boom, collapsed on the floor the next. The second they roll through the doors, the room just erupts. The monitor starts screaming at you. You lean in, the patient is trying to talk, but the words are just garbled. And then you see it. Their face is drooping on one side. Your team just descends. You hear that sound. The rip of clothing being cut away as IVs are going in, oxygen's being applied, the clock has started, and believe me, it is ticking fast. Okay, so you're at the head of the bed. All eyes are on you. What's your first move? What is your #1 priority right now? Let's break it all down. First up, we've got to talk about the one diagnosis you absolutely cannot afford to miss: stroke. And in this world, there is one single rule that governs everything we do. Look, this isn't just some catchy phrase we throw around. It is a hard physiological fact. Every single moment you delay means more permanent brain damage. You see this number, 1.9 million. In an untreated ischemic stroke, that is how many neurons the brain loses every single minute. That is the kind of urgency we are facing here. Recognizing a stroke has to be second nature for you. We're looking for any sudden focal neurologic deficit. Weakness on one side, trouble speaking, vision loss, and that thunderclap headache. When a patient says it's the worst headache of their life, that is a massive red flag for a subarachnoid hemorrhage, which is a catastrophic bleed in the brain. So before you even think about doing anything else, you need one piece of information above everything else. What was the last known normal time? This single data point dictates your entire algorithm. It's what determines if your patient is even a candidate for our most powerful time-sensitive treatments. And this timeline just shows you exactly why that time is so critical. We have this precious tiny window, less than 4.5 hours, for fibrinolysis, using clot-busting drugs like TPA. Now, for some patients with really big clots, we can go in and physically pull it out with a thrombectomy, sometimes up to 24 hours out. These interventions can literally turn back the clock on a stroke. But before any of that can happen, we need one test, and we need it immediately: a non-contrast head CT. Why? Because we have to know, is this patient bleeding in their head? Giving a clot buster to someone with a hemorrhagic stroke is absolutely catastrophic. Okay, here's a little clinical pearl for you. Don't ever forget about posterior circulation strokes, the ones in the back of the brain. They can be really subtle. Just remember the deadly Ds: dysphagia, diplopia, dysarthria, and dysphonia. If you see these signs, you gotta be thinking about the posterior circulation. All right, let's switch gears. What if your patient wasn't weak but was shaking uncontrollably? Now we're in the world of seizures, where our management follows a really clear, stepwise algorithm we call the escalation ladder. First things first, we have to define the real emergency here: status epilepticus. This is not just some brief seizure. This is a brain that is stuck in a state of continuous seizure, and it's actively causing damage. You need to know this. Any seizure that lasts longer than 5 minutes is status. Period. So our approach is an escalation ladder. First and always, the ABCs. Protect that airway. Then we hit them hard and fast with first-line drugs, benzodiazepines. If that doesn't work, we climb the ladder to second-line agents like phenytoin. And if the seizing still continues, we prepare to take over their breathing, intubate them, and start a continuous infusion to put the brain to sleep. Now, just a quick practical point on our first-line drugs. In the hospital, with a good IV, lorazepam is fantastic. But what if you can't get an IV? You gotta know that intramuscular midazolam is just as effective. It's an amazing tool, especially for paramedics out in the field. And here's your key takeaway for your exams and for your practice. With any patient who is seizing, the very first test you must do is a bedside glucose check. Hypoglycemia is a super common and, importantly, an easily reversible cause. And you always have to be hunting for red flags that suggest this isn't just simple epilepsy. Things like trauma, a fever, or a new neurologic deficit. All right, let's move on to our final scenario, and maybe the most challenging of them all: the patient who is just unresponsive. This is a true diagnostic mystery every single time. With an unconscious patient, you have no choice but to go back to the absolute basics. The ABCD approach is your foundation.
That's A for airway, and airway is always king. If their Glasgow Coma Scale, or GCS, is 8 or less, they can't protect their own airway. You have to do it for them. Then B for breathing, C for circulation, D for disability, which means checking pupils, GCS, and yep, a bedside glucose again. And finally E for exposure. Get all their clothes off to look for clues.
So while we're hunting for a cause, we go ahead and treat the most common reversible ones empirically. This is what we call the classic coma cocktail. We give dextrose for low blood sugar, we give naloxone for a potential opioid overdose, and this is critical. For any patient at risk of malnutrition, we give thiamine before the glucose. You have to do it in that order to prevent a devastating neurologic condition called Wernicke's encephalopathy. And this might be the single most important piece of advice I can give you. A patient might smell of alcohol, sure, but that does not mean they don't also have a life-threatening brain bleed or meningitis. Assuming it's just alcohol is one of the most dangerous and deadly mistakes you can make in the ER.
Okay, that was a whirlwind. We've covered a ton of ground in a really short amount of time. So let's boil it all down to the absolute must-know principles you have to take away from this.
Look, if you remember nothing else from this explainer, I want you to remember these 3 things. Number 1, for stroke, time is brain. Number 2, for any unconscious or seizing patient, protect the airway. And number 3, for every single one of these patients, you must hunt for and treat the reversible causes, like hypoglycemia or an overdose. Because in the end, that's what this is really all about, isn't it? The speed of your actions, the clarity of your thinking. It doesn't just decide between life and death. It decides whether someone walks again, talks again, and goes back home to their family. You're not just saving a life, you are saving a future. The only question is, when that clock starts ticking, will you be ready?